4 speakers with us, and we have 3 moderators. And I'm so happy to have Ravi and Dr. Ganpati with us, 2 stalwarts in their respective fields. And as you all know, Ravi is the now editor-in-chief of the DAY, and it gives me tremendous pleasure seeing this young boy growing up into the editor of an international journal. And it's a great thing, great achievement. I think it deserves it. And Dr. Ganpati has come from the court of London, Ontario, Canada. She is a pioneer of regional anesthesia in Canada and the Western Hemisphere. So I am so privileged to have them with me as co-moderators. Rather, I am their co-moderator. And we have 4 papers, but one speaker, Dr. Mark van der Velde from Belgium, for some reason he couldn't attend this session, but we have a wonderful thing stored for you. Dr. Ganpati has agreed to put up a case and discuss with you that case. So I think she deserves a hand for filling in that. So we start with the first paper, and everywhere I go, law and legal things looms large on my head, and then there is a smiling face always comes out of that of Sunila, says, not to worry, I am there. So she is an expert on medical ethics, she is an expert on legal matters related to anesthesia. So I invite Dr. Sunila, who is working with Fortis and as the Chief of Anesthesia Services. And Sunila will talk to us about what constitutes informed consent in regional anesthesia. I think it's a very important subject. Dr. Sunila.
Good morning, everyone, and thanks for the invitation. I feel honored to be here while you are chairing. You are my mentor. Thank you. Allegation of improper informed consent. According to an ASA close study, informed almost less than 1% of their files. But it is included as an additional allegation as a concern by defense counsel, criticized by expert witnesses, and it influences the evaluation, defense, and resolution of any anesthesia malpractice litigation. Informed consent, which we all know now that it has been so much talked about, is a process in clinical practice by which the doctors incorporate the patient's value. Remember that you as witnesses don't want blood transfusions, their preferences, their expectations, fears in the treatment, and the decisions that they would like to take to what should be done to their bodies. After imparting general information about the techniques that you are going to use, the risks involved in it, and we know that in regional anesthesia, as you mentioned, so in a small little sphere, there's a risk of nerve injury, there's a risk of allergic reactions, scissors, hematoma, and infection. The prerequisite for any informed consent are 4. One is the age, which is a decision-making capacity. In our country, it is 18. There should be mental capacity to take a decision, voluntary decision, and information which has to be imparted by the doctors for taking informed consent, on which the patient is going to base the decision. As per law, informed consent is a contract, and it's a contract for services, and this is an agreement under Section 13 of the Indian Contract Act, which is enforceable by law. And it states that 2 or more persons are said to consent when they agree upon the same thing in the same sense. And these contractual relationships, they promote individual autonomy and freedom of choice as per our Constitution, Section 21. This informed consent transforms the essence of doctor-patient relationship to a contractual one, and it also forces the doctor to give the patient the knowledge that will make him or her an equal bargaining partner. Gone are the days when doctor was, was the parent or could suggest or probably get it done. Now the relationships have changed with consumerism and financial. There are a lot of implications in private sector about the finances. There are two legal standards which are generally applied. There are different standards in UK and USA. UK, actually we started with following the UK practice, and now we are in between. We are supposed to even follow the USA pattern. It was a reasonable practitioner pattern or a doctor-centric pattern in UK, where a doctor would decide what to tell so as not to unnecessarily frighten away the patient. In India, we follow suit, and soon we find the USA pattern meant it has to be patient-centric. Patient has got to know what is going to be done to his body and what is going to suffer. Suppose there is an injury comes, because he's the one who's going to suffer it. So we are right now like a trickle, but we are trying to follow even the USA pattern as far as possible. The general information sheet is a very important part of the whole thing. It should start with an information sheet which is in a simple spoken language, as we do for many clinical trials also. Let them read it, talk about it in a simple language, and go ahead with an explanation of the regional anesthesia, the technique, the specificities of the technique, whether you are going to use a nerve stimulator or an ultrasound, a local anesthetic, or the problems with a local anesthetic, and infusions if you intend to use with a catheter, and about the quality and efficiency of the block. You've got to tell them about whether they will need an additional sedation if they are very fearful of a block, or even a general anesthetic supplemented with a block. The risks and the hazards are the ones which take you to court, and which are underplayed most of the time because they normally do not occur to that frequency. But as I'll tell you, what are the material risks which are expected to be told by the courts? Inform the patient in epidurals about the intraoperative sensations that may be residual and may be needed to be converted to complete general anesthesia, headaches, allergy, urine retention, loss of bowel control, numbness, delayed recovery, a small little numbness and paralysis in the distal part of their foot. They are actually quite distressing for the people who suffer. As I told you earlier about the continuous infusions, the duration of weakness, give them also instructions about the precautions they have to take once their limbs are numb, and also a contact number where they can contact them and get some information and advice whenever they are in trouble. For the material risk, it's believed by the courts and the legal people that we must include those that are of very high severity or a high frequency, and death is one of those high severity, though we actually do not want to talk about it. But if we could put it in a perspective, like if it's an AS1 and I'm doing it, we always put it in a perspective, if I cross a road or I'm traveling by a train, I don't know what will happen. So that actually makes it that there are uncertainties in the process. For the more serious ones, one person may be sufficient to be a material risk, like this paralysis, residual paralysis that a patient may have. A less serious one, 3% is a sufficient material risk. So the specific risk everybody knows, we have already talked about it, but there is also back pain, and there may be the incidences which I found in 2007 anesthesia analgesia. Peripheral nerve block is less than 3%, central blockage is 0.04%. It is quite less, but there may be significant residue. Remember, the patient's perspective today is that if the patient has a result he doesn't like and thinks that he would not have had the procedure, especially the elective procedure, if he had known about the potential result, it is definitely the law is in his side. If the doctor didn't tell him about the possible outcome, patient thinks the result must not be a risk of the procedure, but was caused by doctor's negligence. So the justification of regional anesthesia, suppose there is a rare occurrence of a numb finger following a nerve block, maybe just 0 to 3 in 10,000 cases. But it is very unfortunate and a preferable outcome for a doctor or anesthetist who is making a difference between whether you should give a GA or regional anesthesia in presence of so many comorbidities. That may be compared in the perspective when he is talking to the patient to a disaster or induction of a general anesthesia with graver risk of oxygen mishaps. So the counseling for regional anesthesia, patient should be told about a large, one is the own experience, but it is always better to substantiate with the evidence and tell them about a large outcome study to explain why nerve block is safer than a general anesthetic. The outcome study in favor of regional anesthesia, that showed no cardiac arrest, no episodes of respiratory failure, no deaths following upper-limb blocks in over 23,000 anesthetics performed, and very low incidence of peripheral neuropathy may be a better way of talking to the patients. The verdict is in. Anesthesiologists also are now probably, they have to start implementing an anesthesia-specific consent form and the information sheets telling about the inherent risk of whether general anesthesia or spinal anesthesia, anaphylaxis, cardiac arrhythmias, delayed recovery, and numbness. So this is an important risk management strategy which has to be undertaken now quite fast instead of continuing to debate on its merits. The shield to litigation is effective involvement of the patients in their own health care. No amount of documentation is absolute shield to litigation. Though there is a brighter side to it, the Section 88 of Indian Penal Code protects the doctor from a possible allegation of causing any harm or injury while treating the patient once the consent is obtained. Though there are areas, how they find who took the consent, whether really the doctor really talked, is by whenever there is a defense counsel, he will ask the patient's relative patient who gave the consent, whether it was a clerk, a nurse, did the doctor talk to them, and remember, that is the area which is grey and the doctors can't get away because the truth and the law is to one side. There's a softer corner and they will not tell a lie really. One page informed consent may be better because they are less susceptible to arguments of non-comprehension than have pages and pages of those informed consent. So take home message would be informed consent process can be challenged in courts. Communication, information, and confirmation that this information is understood. Documentation, giving autonomy up to the patient of deciding what is good for him, especially during the elective surgery and during emergency also, though the law is on our side. But there also you must tell him what he is going to achieve when you operate, even in emergency. So information, documentation, action to save life or limb in emergency. In elective, you've got enough time to really talk about all these things. So implement informed consent. It will substantially remove the effectiveness of one tactical weapon in all the complainants' attorneys' litigation arsenal that consent was not taken or consent was inadequate. Thank you.
Thank you, Sunila, for sticking to the time and of course for giving such a beautiful account of the subject. Open for questions.
Sunila, do you have to tell the patients about some rare or very infrequent complications arising from the drugs, which may affect the patient's life?
That is what it is. Yes, because why I'm saying is, even if it is less than 1%, if it is going to affect their life, it has to be, you must sit down, tell them about, you have to really balance between like a counselor and information. You have to tell it, because there's a case we went into the legal arena when the complication was very rare and probably every doctor is expected to be up to date with the information. But they could have given him some leverage, but the thing was that particular doctor had written an article on it, published it, and the same complication occurred with him. So this plea that it is rare was not entertained. It was held in business. So there are a lot of circumstances.
Sunila, ma'am, actually I do have a question. Since we work in the same organizations, we do have a consent which is pre-formed and pre-written, and we follow that same format. And the lacuna that I found was that the process of consent is not followed.
I agree.
I would like you to elaborate on that.
Yes, actually, Dr. Panigri is not here, so he's one of our senior people who has been trying to make it 4:1, making one consent which is uniform, like we have, for the passport or something like that. So he's trying to do that. But when I was studying law in Bangalore National Law School, in the lectures, what they said was, the consent has to have a place where you're going to write specific to that patient, the alerts, that particular thing is missing. I brought it out, but somehow I said you can have now additional whatever you want to do in the second part of the consent. So they are going to introduce a uniform consent with a back page which will be patient specific. So we will probably do it. We have to write what are the alerts in that patient and what are the basic techniques which becomes patient specific.
And another thing that I wanted to point out, whenever you write a complication, you have to write the incidence of the complication as well, as pertaining to general.
Actually, incidents as such, if you see a possibly may not make much sense, so you must also talk about it.
And for some reason, because of my high blood sugar, my surgery is postponed for let's say 2 months. So when I come back, do I have to reconsent? Do I need to take a reconsent?
There is a validity of consent. Normally they say up to 1 month, but it is always good that things might have changed, the circumstances may have changed. So it may not be a bad idea to do it again. They say 1 month. The validity in the same admission, and then again when you come for the next place, a new consent.
In this thing, I would like to cite one incident which we had recently. We took up a patient for exploratory laparoscopy, and the patient was a perforation peritonitis, 16 years old, suffered a cardiac arrest immediately after internship. The tube was in, patient was neurologically stable. We woke up the patient and we had to change the procedure. So we had to do the whole process again. While the patient was in the OT, we had to call the father, showing that the patient is neurologically intact, and then proceed for a different procedure in which the surgeon just put the blind drains in the abdomen, and then later on the next day we operated the patient again with a fresh consent. So for every step of the procedure and change of procedure, we have to obtain a consent.
So I would say, because in this, the surgeon, especially when the surgeons are planning it maybe laparoscopic, maybe converted into open, there is a doctrine of prior consent, and they're supposed to talk about it to the patient, because there is a landmark case from the Supreme Court judgment where a gynecologist took a consent for a diagnostic laparoscopy, found endometriosis, and then sent one of his team member to go outside, take consent from the mother who was sitting. She was a 44-year-old unmarried girl whom she was operating. She could have easily come out, but she preferred to do a hysterectomy on her, and the patient sued her. And she's a living legend. She's actually a practicing gynecologist, I know her. And she said, you have got no right to decide. I want you to have children. So remember, don't try to be a parent to a patient. Come out at that stage. It's not an emergency surgery. It is elective surgery. You can go back again and take that patient. Don't think you उसमें पैसा ज़्यादा लगेगा उसमें नहीं लगेगा. Or prior consent. Anticipate those things. Take that consent.
Only patient consent is sufficient or relative consent?
I would always say to have the witnesses, because if a patient dies, it is the, whether it's the financial implications or whether the death of their own one, they should be a witness. It is always good for us. And if there's nobody in the patient, try to take the neighbor's person as why you are talking to this and document to take his witness.
Thank you very much. I think I'll definitely ask my co-moderator to see if they want to ask some questions. So we can go for the next paper. Thank you, Sudhir.
So how many of you have had nightmares recently? So if this is the morning after nightmares, then Professor Ganpati is going to deal with it. Those of you who weren't here yesterday, Professor Ganpati is from London, Ontario, and she's very well known in her field of regional anesthesia. Great educationist, great researcher, and we're really very fortunate to have her here amongst us.
Thank you for the kind introduction. This topic is supposed to be covered by Dr. Mark Van der Velde, and I presumed he was going to talk about acute post-block neurological deficit. But maybe the morning after sounds more like morning after pill. So this is a different case scenario. I'm just going to present one of the cases we have had recently. This was a 60-year-old.
She's not going to say.
About the ma'am, what about the consent if we have encountered the unknown patient like roadside accident when there is no relative, then
You know, there is a consent for emergency, save the life and limb, and that's all limit yourself to that. If it is dangerous, it is not going to affect the life. Wait if you can, but yes, you can not only alone, take your surgeon along, take your administrator along, all sort of things, so any test will be documented.
normally nobody
Lunch hour,
gets
lunch
ready.
hour, please.
Okay.
Don't get to eat lunch.
Okay, and this case scenario pretty soon follows on what she has advised you to do. This is a 60-year-old morbidly obese female, BMI of 58. She was posted for revision of total knee joint replacement. She was put as the last patient on the list, which is unusual in my hospital. They are usually the first on the list. Maybe because she was infected, they wanted to keep her to the last. She was narcotic dependent, hypertensive, mild diabetes, sleep apnea, smoker, non-specific STT changes on the EKG. She was seen in the pre-admit clinic by a cardiac anesthesiologist who never discussed anything about peripheral nerve blocks. Okay. And when she appeared on the pre-op holding area, my fellow went and talked to the patient. They discussed sciatic catheters as well as spinal anesthesia for her surgery. So we brought her to the block room, did a femoral catheter, loaded with 0.2% ropivacaine for femoral and 15 cc's and 0.1% ropivacaine 7 cc's for the sciatic. And then we gave her a spinal anesthesia. We connected her to a PCRA for only the femoral. The sciatic was a continuous infusion, which was to be started after they document foot movement. That is a standard of practice in our hospital. So the spinal anesthesia was done with ultrasound assistance. That means we counted the space, we found out where the depth was, the midline, and he had to make about 3 passes with a 25 gauge. We took the longer needle because she was quite chubby in the back. And he injected 15 milligrams of hyperbaric bupivacaine and waited for 2 minutes and gave another 10 milligrams of hyperbaric bupivacaine. The whole idea being, fractionation may prolong your spinal anesthesia by about 20-30%, then I don't have to intubate her halfway through her surgery. And she was also given pre-operative and post-operative multimodal analgesia. The surgery lasted 4 hours and the spinal anesthesia was adequate for her. And the tourniquet was up for 140 minutes at 350 millimeters of mercury. And I called it minimal blood loss. My college came, and when you cross 60 in Canada, the college will come and evaluate they will check 20 of your anesthetic records randomly to correct in case you're making mistakes or if you're not documenting things that should be documented. So they wanted me to document blood loss on these patients, which is, when it is done under a tourniquet, is kind of moot point. Anyway, she had minimal blood loss. And apart from the routine multimodal, we also put her on clonidine 0.1 milligram POBAD because she was narcotic dependent. The next day morning, when the fellow went to see her, the nurse complains that the patient has not moved the operated limb since she came back from the OR. Pain scores have been 3 out of 10. They had to catheterize the bladder for retention. You must be wondering, why didn't they do it in the operating room? That is some cult in London Health Sciences Centre. They believe that bladder catheterization adds 10 minutes to the operating time and they don't want it. So they will do the catheter if needed, which I loathe, because you're going to do the catheter when the plasma level of the antibiotic is on its trough. Patient is worried as to why she still cannot move her leg. What will you do? Any ideas?
Give it the mic, please. It's a serious matter. Give it a thought and then answer. Don't jump into conclusions.
you had a sciatic nerve infusion going on, the first thing would be to stop that infusion.
Okay. The sciatic hadn't been started because the instruction was when she starts moving her toes, that's when they can stop the sciatic infusion. Good idea, yes. Any other suggestions? Okay, I'm going to say what we did for the sake of time. We went and saw the patient. We examined the patient neurologically, sensory, motor, and plantar reflexes on both sides. It's just not one side. Look for signs and symptoms of compartment syndrome. What will be the 7 Ps? Pulseless, pale, painful, and when you stretch it, sometimes they have more pain. So none of those things were positive. We stopped the femoral, the sciatic infusions. The sciatic hadn't been started, and we inspected the sites. The catheter seems to have been in good location, and we made sure the patient was receiving the correct drug and dose in those blocks, because there are occasions when people have booked up the wrong drug to the peripheral block infusions. Particularly, we have floating set of nurses in the evening due to nursing shortage. They are called nursing reserve units. They're a disaster for me. They went and gave 100 milligrams of ropivacaine intravenously because it looked like vancomycin up in the floor in a 91-year-old. So you keep that in mind. Never trust that they have connected the correct drug. Oral narcotics for pain, if it was more than 5 out of 10 is what we ordered. Urgent consult to neurologist and booked for an MRI of the spine. The MRI report came back as no spinal hematoma or injury to the spinal cord or conus medullaris noted. That was the greatest relaxing feature, okay? The foot movements gradually returned by the time she came back from the MRI by noon that day. The quad strength gradually improved over 4 hours to 3 out of 5. Contralateral leg preoperative strength was 4 out of 10, and it had come back to 4 out of 10. Patient complains of pencil needles in the operative foot, lateral thigh, and numbness as the only ongoing symptom. And she's requesting for some help with it. Oh, I can't sleep with this, it's really bothering me. What will you do? No. This patient had only peripheral nerve block catheters and a single shot spinal which was fractionated, total of 25 milligrams. Yes, she was already on Lyrica. So what we did, we bumped the Lyrica dose and we called the surgeon again. Could you make sure there is no compartment syndrome? The paresthesia again is a symptom of compartment syndrome. She has had major surgery, she's obese, and the tourniquet has been up for 140 minutes. Beyond 120 minutes, you can have much more injury to the tissues, including the muscle and the nerves, microneuropraxia. So then eventually she had nerve conduction studies done on the advice of the neurologist, which showed bilateral tibial and peroneal increase in latencies, noted distally, as well as lateral femoral cutaneous nerve territory, increased sensory latencies. Neurologist notes bilateral sensory deficits below the knee in his initial exam. So this is bilateral, not on the operative side. We reassured the patient regarding plans for observation, not intervening. He also sent to the lab levels of B12. Lyrica was increased to 75 BID. Compartments re-examined by the surgeon, and he was reassured he didn't think there was compartment syndrome. What not to do? Don't panic. Don't own up the neurological deficit to your block. That is the greatest mistake I did up until recently. Even now, there will be a note in the chart saying, possibly due to the block. I said, no, don't write that in the chart. That's a medical legal document. Give me a chance. So I always go and document. And if I feel it could be due to the block, I could also concur with it, possibly due to the block. But I don't make them write due to the block. Okay? And then do not label this as relating to only anesthesia. Patient gradually improves over the next 3 days. What was the diagnosis? She possibly had preoperative diabetic neuropathy with exaggerated response to local anesthetic. It lingered on much longer in the, the diabetic nerves are very sensitive to local anesthetic. I have used only 0.2%. Even that was too much for that piddly little nerve. So he adds some vitamin B6, B1, B12 supplements. He checks her hemoglobin A1C, which returns as 9.5. Normal should be 6 or less. So the repeat exam at 1 week reveals persisting numbness and ongoing tingling only on the lateral aspect of the thigh. The majority of all the other symptoms have disappeared. That means she has gone back to status quo, preoperative status quo. So what were the differential diagnoses that we wanted to consider? We wanted to consider spinal cord injury as a possibility because she's obese. These patients can be very difficult to do spinal. Although I had the luxury of ultrasound, I still made the attempts and she had a paresthesia to the operative leg. That's where her symptoms are. Although I counted with my ultrasound, I could still be wrong because the skin movement sometimes makes you go wrong. Nerve injury due to block or surgery. Don't forget the surgery. There are up to 0.1% chance of getting nerves injured due to surgery. Not everything that happens with the nerves is anesthesia related or block related. Compartment syndrome can give rise to nerve injuries because we have had some patients who develop compartment syndrome following high tibial osteotomy. Some of them have completely necrosed out their peroneal nerve and they are in neuropathic pain now. So you have to keep compartment syndrome in mind because that requires urgent attention. Don't ever forget compartment syndrome in some of these patients. Diabetic neuropathy was the diagnosis, neuralgia paresthetica. A combination of things is the commonest cause of neurological deficits. More aggressive control of sugars was planned. Where did I go wrong? This was not picked up adequately in the preoperative period. And the patient was not informed about this. First of all, not picking up the peripheral neuropathy of diabetes. Second thing, not informing the patient that she's more susceptible to neurological injuries. Those are the two mistakes that we did. So if it goes to court, yes, I've got some thin ice to walk on. Possible steroid injection for lateral femoral cutaneous. I wouldn't invade any nerves in her at this stage. I will let her ride for a few days and then once this acute phase settles, then I will attack her. Neurology to follow up and they are the best people. And then once you have communicated with the team, the communication to the patient becomes much easier. Their brain is not brainwashed, oh, the anesthetist dinged my nerve or something like that. So that is an important thing to remember. Perioperative nerve injury after total hip arthroplasty. It's a 20-year cohort study done by James Hebbel, but he thinks those are relatively uncommon. So I'm not worried about the surgical injury with the hip arthroplasties. But what about the knee arthroplasties? Nerve injuries after knee arthroplasties can be more frequent. Nerve injuries after hip and knee arthroplasties were rare in large population of patients younger than 65 years. Although the overall rates were low, there was an increased occurrence of nerve injuries in the diabetic population. So we've got to tell them before we stick needles to diabetics, you have more chances of getting injured both due to surgery as well as due to my block. So that is the important information with regards to consent that we have to take with regional anesthesia. What was the clue? How did we decide it wasn't my nerve block? We decided because it was bilateral. It included the sciatic territory and as well as the lateral femoral cutaneous nerve territory. Can I get the lateral femoral cutaneous nerve affected by my femoral block? The chances are very small. My drug doesn't spread that far laterally. So I always have to do an LFC and block separately if I want that area anesthetized. So that was a clue to us. And the last but not least, you're right, position. This woman is so obese and there was such a big palace and they have the hip flexed at 90 degrees and banging away, and that certainly can crush your lateral femoral cutaneous nerve. Special advice will be consult neurology early. Don't be proud. Don't think you can do a proper neurological exam. When did I last do my proper neurological exam? When I was an intern or when I did my medicine residency initial course rotation. That is how many years ago. So I cannot be as good as a neurologist. Do a bilateral exam. Don't stop only with the affected limb. Reduce local anesthetic dose in the diabetics. Don't forget to remove the block catheter. This is another thing. We decided it is not a block. We stopped the infusions. But you can forget with all this schmoz that's going on to remove those catheters. So always make an order to remove the catheters because if the nerve is irritated, presence of a catheter beyond 48 hours is a sitting duck example for producing infection, nerve irritation. Make sure you remove the catheter. People forget with all this conundrum that's happening. Preoperative informed consent in diabetic with neuropathy and regional anesthesia. Review your ultrasound images to rule out intraneural injection. Sorry, it's not intraneural. Intraneural injection. How many of you store your images? Put up your hand. If you do a block in a patient, do you store your images for review? I certainly don't, because it occupies too much of my storing area. In the US, it has become a standard of practice. First of all, they have to store the loop for a certain period, and they also print certain stages of the block on a printer and put it in the chart, otherwise they don't get paid. In Canada, we don't have that. We don't get paid extra for the ultrasound use. And I don't store it because it becomes a nightmare to keep the confidential storage locked up. I find it an impossible task in my system because so many people use the same machine, and I really don't know if somebody else would have taken those images, and I have lost the privacy of the patient. So I don't record loops unless I have some suspicion. If I suspect that it is going intraneural, we just click just for a review at the end of the procedure, but I don't store it. So it's not a bad idea, but you need a humongous storing space or the QLab to upload it into a big server. I'm not there as yet. How many of you upload it to a QLab or an, okay, good. Thank you, that's it.
Thank you very much, Mr. Ganpathy, for an excellent case presentation. I can see a hand up, burning question.
Can you use the microphone?
Can you please pass it? In India, we have another sort of problem. I'll just tell a short case presentation. We had one joint surgery done in private nursing home in Mumbai by one of my anesthesia colleagues. The first joint did very well under CSC.
Someone has collapsed.
Everything went off well. After 1 week, the patient came for the other joint. The same anesthesia was given by the same anesthetist for the same patient. A CNC is given, the patient was fine for 48 hours. When he took out the catheter, he felt that the patient not moving next to him. And then he informed his orthopedic surgeon, who is also a spine surgeon, and told him you get a neurology opinion and you have to get the MRI done. So the orthopedic surgeon says, I'm a spine surgeon, I know when to get the MRI done and whatever. So there was slight delay in that, and then he does the MRI. MRI shows a small epidural hematoma, and he decides the management and he says there's nothing required to be done. And the paralysis continues, and the patient is wheelchair bound, and then there is a case against both anesthetist as well as the surgeon. So what does the anesthetist do in a situation like this? He knows he has to call the neurologist and the MRI, but the orthopedic surgeon who is treating the patient says, I'm the boss, I know what to do, so it's okay. And there's a case against both of them.
Take orthopedic surgeon consent also.
You must document that we need neurologist consultation.
It's
Like neurologist
documented on the
consultation and
file.
MRI, you have to document on the file.
Yes, it's documented, but the case is on.
Tremendous because everybody wants to have a lot of compensation, and they know that most of us, whether we are or not paid by insurances, now that in National Commission law it's gone more than crores. We had recently had a case of 6.5 crores sanctioned. So what we have to do is, yes, documentation, yes. Try to get whatever your orthopedic surgeon thinks so. Try to see, I know you can't bypass this, but if you find that there is something that you believe in and you think it's an epidural hematoma, try to involve even your hospital administrator. We try to do that.
Take orthopedic
Because this
surgeon
happens because
consent
they will
also.
not allow you to do it because it's their patient, very possessive, but you also have to say that you will, anywhere you put, it will be ultimately decided. Because they, even if it is against it, I think we all will get used to it ultimately.
If I come from the humanitarian point of view, forget the legal system. Legal systems are different in different countries, different lawyers lawyers play differently in different setups. If you think, as a doctor, that your patient is in trouble, requires some intervention, whether it's the surgeon you've been working with, your own colleague, whatever, and they are being obstructive, you can always go to your head of the department, your own colleagues, second opinion, third opinion, that's fair game. And if you then, I would challenge to my surgeon, say, you might require a second opinion here, and document that. Let him refuse second opinion. Then he takes more responsibility.
So this happens in institutes. This is about a nursing home.
Wherever, doesn't matter. You can always take second, third, fourth opinion. More opinions you have, better it is for you.
There is something called risk management. We have a whole group of people employed in the hospital, including a legal system, risk management. I will not hesitate to call them, can you sort this out? This patient has to have an MRI right away, in my opinion. Help me is what I will tell them. And they have a fantastic way of talking to the tough surgeons to get them to consent to what is necessary for the patient. So as a woman, that particularly happens with women. We all are sometimes very weak. We don't raise our voice. And if it's a dominant orthopedic surgeon, you may not get it. I mean, it's evidence. It's not just in Canada.
Dr. Ganpati, your patient, the one which you were talking about, I agree that she was a diabetic. This was a re-surgery. This was a revision care. The previous procedure must have been done under regional as well. She didn't have any problems with that the first time.
I can't remember all the details actually. It might have been done in a peripheral hospital. And as far as the patient was concerned, there was no problem. That's why she had consented for the spinal. But she didn't have a block for the primary. The block component was specifically because it was a revision. By then she had gone on too much of narcotics. So narcotic dependent patients for revision will get a block from it.
The other thing I wanted to ask you was, you didn't want to inject steroid into the lateral cutaneous nerve, but had she not been a diabetic and that too a bad diabetic, what about oral steroids in this patient? Would you given that? If the symptoms had been a little more severe, say, and they were not sort of, if she wasn't responding as well, what would be the management in that situation? The MRI is okay, there's no hematoma, there's definitely a nerve which is giving problems and giving more problems than, and it's not recovering as fast as you wanted to, and you don't want to inject steroid into that nerve or put any needle around it. What about oral steroids, or what would you do in that situation?
I don't believe in oral steroids. In that it's particularly more risky. It will make her diabetes even worse. I don't know about her wound healing because it's already an infected wound. And obese patients in our hospital statistics show they've got the most problems with wound healing. And I don't want to make anything that will make wound healing even worse with them. And the symptoms are not that bad. Some tingling and numbness on the lateral aspect of the it's not life-threatening for her.
Why I'm asking you, ma'am, many years back now, it's been almost 13, 14 years back, I had one patient, she came for a cesarean section, and it was a very straightforward single shot spinal with fentanyl 20 micrograms and bupivacaine, and patient was fine post-op. The next day, after she got better, she started complaining of a little tingling in her right or left gluteal region. And so we thought by next day it would get better, but next day it was even worse. The patient was almost in tears. She was postpartum. She was like going through a lot of other issues. And it only got worse. When we got an MRI done, which was normal, there didn't seem to be, looked seriously like a case of transient neurological symptoms that she had developed. So this patient then was started by on oral steroids by our, but in that situation, what would you have done in that case?
In this patient, I gave her one physical maneuver. She had a panus hanging like almost to her upper third of the thigh. So I told her when you're lying down, you just lift up your panus to go on the opposite side to take the pressure off your nerve. I reassured her, give it about 1 or 2 weeks, it will get better because the perioperative edema will come down. She's all waterlogged with the perioperative stress response and everything. Once that edema comes down, they feel a little bit better. So I don't rush into injecting near these inflamed nerves right away, unless it is a problem that it is totally destroying her quality of life. If you reassure, they accept this.
Yeah, but that patient actually got, the symptoms were not getting better. And finally, my pain colleague started her on oral steroids and she got better actually. She started improving and she did. So that's why I just wanted to find out what else could we have done? I mean, this is now almost 15 years back. I've never had a patient like that again. But that one case I always remember because she happened to be a VIP as well. So there was a lot of pressure.
You titrate therapy to individual patients. We cannot carry on a blanket. This is what you do like that. You have to manage individual patients, taking the risk benefits of starting with
I think I've been constantly reminded by the young lady next to us that we are running behind the schedule. So I think all the questions can wait. I know everybody has some experience or bad experience regarding this. One point I just want to add, that any patient who is immune compromised, be careful. Diabetics are immune compromised. And be careful about giving regionals, particularly spinals. You have to explain to them, and Sunila will tell you what to do with them. I think we go to the next speaker.
Okay, so we have Dr. Guru Prasad. How to document and audit your regional blocks. So we've talked about all the problems, we've talked about the medical legal aspects, and now we come to documentation and auditing.
Good morning, everybody, respected chairperson and my dear delegates. The topic document and auditing, I think it's very difficult to finish in 10 minutes, but still I'll try to do that. A non-academic thing. This is a statue of Basavana. He is a 12th century Indian philosopher and a social reformer. And this is a statue which has been erected in my hometown, Gadag, and it is supposed to be the 6th tallest in India. I'll cover up the topic under these headings. And documentation gives you a complete record and are the cornerstones of quality healthcare. It helps in it is a communication vehicle with other healthcare providers. It provides information for planning continued care. It's used for quality assurance, billing and reimbursement, and last but not the least, it is the best tool for defense of medical malpractice claims. That's all the discussion is about. So, this is what happens. Where would we be without the right documentation? I think unemployed is much better than being behind the bars. And this is the golden rule. If it isn't written down, you didn't do it. We have got various anesthesia techniques, the general anesthesia, the central neuroaxial blockade and the peripheral nerve block. General anesthesia and central nerve blockade, the system or the standardization for documentation is ready, but it is not standardized in peripheral nerve blocks. So to start off with the documentation, then we have got a printed sheet where the institution name comes, then the patient's name, medical record number, age, history, the clinical examination findings, significant medical history, medications, especially when we are doing the blocks, if the patient is on some anticoagulants, we have to be very careful and document it. Allergies, especially to the local anesthetic. Airway assessment is also important and to be documented, because though we think of doing it under a peripheral nerve block, still in case the block fails or is partial or we need for resuscitation, we have to plan it before, and that even the assessment should be documented, airway assessment should be documented, then the ASA grading and the risk. Next, the date and time of the surgery should be written down, whether it's a daycare or an inpatient, the name of the surgeon, what is your pre-op diagnosis, and the planned surgical procedure. Going ahead, you have to mark the site whether the surgery is on the right or the left limb, whether the consent of the chart, like how Dr. Sunila highlighted. Both the surgical and anesthesia consent should be documented. The laterality check, the timeout has to be performed before the incision. This next one, it's not that common in this part of the world, but in the Western countries, who requested the block? The surgeon's name is put there. Then the blocks performed, if you have performed only one block or two or a combination of many blocks, that has to be documented. The procedure start and end time, the vital signs of the patients, what pre-medication was the patient on, whether the patient was awake, sedated, or anesthetized, or was under other regionals when you started the block, has to be documented. Asepsis is a very important part to be documented, whether the anesthetist had a sterile gown, gloves, whether what antiseptic solution he used to paint the injecting area, what was the patient position, whether it was supine, lateral, right lateral, left lateral, or probe position, and whether all the monitoring, ASA monitoring devices, standard devices like oximeter, NIVP and ECG was applied, whether all the resuscitation equipments and the drugs, especially the lipid emulsion, in case of opioid toxicity, was ready, whether the patient was on supplemental oxygen, whether the technique which was used, was it a single shot or a continuous? If it was a continuous, how deep was the catheter left at the skin mark? That has to be documented. What type of the needle was used, whether it was an insulated or a non-insulated needle or a echogenic needle, the length and gauge of the needle which was used for the particular procedure, whether you infiltrated the skin before the block procedure. Then the monitoring aspects for the peripheral nerve block, in particular the ultrasound, whether the ultrasound was used, and if it was used, which was the transducer used, whether it was a curvilinear low frequency or a linear high frequency probe, and whether it was on a in-plane or out-of-plane technique has to be documented. Then whether blood was aspirated, yes or no, and did you give an intravenous test using adrenaline, whether it was positive or negative, whether the patient had pain during injection, whether there was resistance to injection when during the block procedure, if at all, whether resistance less than 15 psi, which is quite safe, and whether it was higher than 15 psi, then whether you had to give an additional rescue block because the block was partial has to be documented again. What was the motor response accepted before you went ahead with injecting the local anesthetic, and what was the minimum current accepted, whether it was more than 0.2 milliamperes or less than that, whether the ultrasound image what you got finally was clear or not that clear, if at all the local anesthetic used, whether the concentration of the drug, the volume which was used, and not to forget the batch and the expiry date should be documented. Whatever additives you had used, whether it's a dexamethasone, clonidine or a fentanyl, that has to be written down. If at all the patient was on continuous catheter infusion, then the rate at which it was set, and if at all it was a PCA, then what was the rate of local anesthetic going on, how frequently it has to be given, that has to be written down. Then any events which happened during the procedure, like if initial injection of a local anesthetic caused some amount of tachycardia or raised blood pressure, that indicating your needle tip was intravascular, again that should be there. Any additional remarks, then whether the block was complete, failed or partial, aborted, and if it was aborted or partial, what was the cause, and did you convert it into a different technique. Post-procedure condition should be noted, the vitals, the level of consciousness, because you would have sedated for the block, and what was the level of consciousness at the end, and last but not the least, the anesthesiologist signature, which is going to carry a lot of weight. So that finishes the part of documentation. A little about clinical audit. Clinical audit usually aims to evaluate how close your practice is to the best practice, and to identify ways of improving the quality of healthcare provided. So any clinical audit is specific and local to one particular patient group, and it aims to improve the services. It is practice-based It is an ongoing process, never involves allocating patients randomly to different treatment groups, and it never involves a completely new treatment. So this is how a few of the audits which have been done, an audit of peripheral nerve blocks for hand surgeries, how effective or whether there were some rescue blocks given. This is another audit on the efficiency of ultrasound, use of ultrasound, and how much was there difference of use of the volume of local anesthetic when you use for when a block was given in an ultrasound or a PNS, and what was the duration of the block even with 15 ml or with 40 ml. If you can see on the audit, you can see that hardly any difference. Then this is one of the big audits which have been done, the preliminary results of Australian Regional Anesthesia Collaboration, a prospective audit of more than 7,000 peripheral nerve and plexus blocks for neurologic and other complications. So there are many criteria like that where you can include in your audits, like the rate of onset with the different techniques or different volume of drugs or different concentration of drugs, and the percentage of patients who had rescue blocks after a particular technique. If you have given infraclavicular, how many times you would have missed a particular nerve, and did you go ahead with a rescue block? On that you can make an audit, and what was the duration of the block with a particular combination of drugs, how beneficial was USG compared to PNS, and these are the different criteria which you can use for auditing. Finally, to conclude, documentation is the cornerstone of quality healthcare, and it is the best tool to defend medical malpractice claims. Definitely with the good documentation, you can look back as to what you have done all the years. Sometimes when you meet people, they say that I would have done about 4,000 to 5,000 cesareans, and that is how they say 4,000 to 5,000 cesareans. The difference is 1,000 cesareans, and it will take another 2 or 3 years to do that. So it will not be a casual figure. You can say that I have done about 4,100 or something like that. The auditing, again, as I said, aims to evaluate how close your practice is to the best practice. But the take-home message is, if it was not written down, you didn't do it. Thank you.
I think in the interest of time, we'll move on straight to the next speaker, and maybe have a few questions after these two talks. So the next speaker today, or the last for this session, is Dr. Kirti Barwal from Gurgaon. How to make regional anesthesia fit into any kind of practice. It's quite an interesting title. I don't know what Kirti's planned, but we are waiting to hear.
Good afternoon, everyone. I would like to thank the organizers to give me this opportunity to speak here in front of such prestigious chairpersons. Right, before I start, I want to request you to please read through this phrase. So in the next 10 minutes, I'm going to focus on re-engineering perioperative care in context with how to fit regional anesthesia into any kind of practice. I'm not here to talk about why regional anesthesia, neither am I going to suggest which blocks for which surgery and which specialty. I'm here to just talk about the practicalities of promoting regional anesthesia in any kind of setup. It could be an academic institute or a smaller private setup. So the first most important thing, the agent of change, is you. Once you decide that you need to change to cause an impact, you can move things. So, well, I'm a bit afraid. In fact, I'm sorry to say that anesthetists in India, they have taken a back seat. It's really important that we come forward. In academic institutes, maybe not. In private setups, yeah, we've come across so many people who say surgeons dictate this or that, or changes our practice. We have to share the responsibility of, patient care as well as the outcomes with them, then only we can get our specialty to due respect. So for this, first of all, you have to train yourself well before you make any changes around. It takes much more than just the technical know-how, and your communication skills, your non-technical or I would say softer skills would be really important. So once you are ready, second, well, we are going to take help of 4 S's, which I'm not yet disclosing. Will be just I'll address them one by one. Second, most important thing, teamwork. It has to be a surgeon. Again, communication plays a big role to take them on board. Not everyone is going to be pro-regional, but you have to spot, the one person, one surgeon who's bright among those to be with you. And, well, you'll have to also address their genuine concerns. Then only you can take them on board. This is a Canadian survey of orthopedic surgeons' attitudes and knowledge regarding regional anesthesia, where they found that surgeons concerned, 43% of them thought that the regional anesthesia causes delays in anesthesia. It's not a secret. That's what our surgeons say here as well. An unpredictable success rate was quoted in 12%. But, well, good news is that 40% of them supported and they directed their patients to get regional anesthesia. And we just need 1 out of these to help us to begin with. Second S would be systems and standard operating procedures. To make an impactful change that lasts longer, you need to have some pathways and protocols from very pre-operative stage up to the post-operative period. Maybe starting from meticulous patient selection. So enhanced recovery pathways are already there. We should try to apply them into our systems. Diligent data collection, as already mentioned, auditing is most important because we'll have to collect the data to prove to other stakeholders, other surgeons, administrative people to help us and take them on board. Quality control, again, is going to play a very important role all through, and patients show safety, and that is the most important thing.